can't wear a bathing suit without exposing the fact that they're being treated for cancer. So by putting it in the arm, there's no trace of it. It was a 14-year-old girl with a type of cancer. And I said, hold on, I can put this in your arm. You're so young, you know? Can you imagine having your chest scarred? PIC stands for peripheral, meaning in your arms, peripheral inserted central catheter. And we published a paper on tunneling from the neck or the chest to the arm so that it looks like a PIC line, but it's in a vein that we can access. I would argue that if you stay in one place, you develop the trust and the relationships that will allow you to innovate. And what I was taught in school, sadly, not even knowing that it was an issue, was if you have lighter skin, it's easier to see the veins. If you have darker skin, it's harder. So you just kind of feel it, pat it, and kind of go where it's supposed to be. And I thought to myself, that's not right. That's not right at all.
Well, hi. Welcome to Health Frontiers with Dr. Bob, and I'm happy to be here today with a very outstanding guest. And I'm going to introduce him, and then we'll have a little chit-chat about our common interests and also, surprisingly, things that we came across together that really were serendipitous in our past. Matt Ostroff is an advanced practice nurse practitioner and the coordinator and founder of the Vascular Access Program at St. Joseph's Health, serving a diverse patient population, which we have from neonates to adults. His program has received multiple accolades, and including the 2016 New Jersey Biz Healthcare Hero Award and the 2023 ANCC Magnet Award for Innovation. Matt received the Outstanding Graduate Award from Drexel University, the 2020 Suzanne Laver Herbst Award for Excellence in Vascular Access, and the 2025 10th Annual Dr. Martin Luther King Jr. Community Innovation Excellence Award for his impactful work. Matt has presented at national and international conferences. The next stop actually is the World Congress in Spain in 2026, focusing on critical thinking in the complex patient scenarios. He continues to innovate with bedside tunnel dialysis catheter insertions, and he'll explain this for you, the patient, as we go. And most recently, bedside port placements, for which he has been honored as the 2025 American Cancer Society's Medical Professional of the Year. It's really something, Matt. Finally, he's the author of Ultrasound-Guided Vascular Access, Practical Solutions to Bedside Clinical Challenges 2022, and has published 30 papers in peer-reviewed journals. He is most proud of his accomplishment in balancing his exciting career with his amazing 4 children. Matt, it's good to see you, and we know each other. And serendipitously, we probably met each other along our routes of growing up together as paramedics and also EMS people. When I was at St. Vincent's, you were apparently training at St. Vincent's. And surprisingly, 9/11, both of us were at 9/11 and didn't know each other at that time when the Twin Towers fell. And that's 24 years ago, going on 25. So it's been very exciting. And you've also been an actor. You can tell us about that on what was the name of the...
All My Children.
All My Children. And you were the medic in All My Children, which is very, very interesting and very, very exciting. And I'm sure we're all going to enjoy what Matt has to say, because if you're involved, as most patients are, with vascular access, that means needles placed in your arm or in other parts of your body, either now or in the future or in the past. You're going to be very interested in this particular program and this discussion. So, Matt, tell me a little bit about intravenous access.
Well, first of all, thank you so much for having me on the show, Dr. Bob. It's always so amazing and great for my specialty when it's recognized by physicians. Intravenous access is the most frequently performed procedure in hospitals, and it's the only procedure that still hurts patients. Whether they're getting stuck for blood draw or for an IV or a central line, it's painful. And right now, everybody does it. Ultrasound is everywhere, whether you're a new student or an attending or a nurse specialist or just a when I say just, the frontline nurses that don't have access to the visualization technology, everybody's trying to get into the veins. And today we have a chronically ill patient population. So they're continually coming back to the hospital, thanks to people like you who keep them alive. But their venous vasculature is being depleted. So how do we get access on those people? And that's what I hope to talk to you about today.
Yeah, this is amazing stuff. And this is something that is of great interest to all of you patients out there because we're all getting stuck. And I do a lot of joint injections and a lot of aspiration of swollen parts of the body. And I try to use ultrasound, but you are actually a master of ultrasound when it comes to placing needles and ports in people.
Well, that's where it gets interesting. There were IV teams back in the 1980s, and patients got their IVs and their infusions and their CT scans so that they could start therapy sooner. And then they got dissolved. So the IVs became just anybody's domain. And then the PICC lines, which are an IV for long-term antibiotics or nutrition, became very popular. And then IVs came back into those vascular teams, but they were much smaller. So they're only getting to 5 or 10% of the patient population. And when you say expert, we can get it in 90% of the time, 97% of the time on the first stick.
Yeah.
And not only does that help the patient, but it saves the hospital and the resources and allows you to get quicker care, quicker diagnostics, and quicker therapy.
Yes, very important because of all the things the patients tell me, and they tell other doctors this too, is they hate to be stuck and missed. Now, obviously, in most offices such as mine, you go to send them to the lab, and sometimes they have a good phlebotomist, and a phlebotomist is somebody who draws blood in the lab. And sometimes they don't have such a good phlebotomist, and they get stuck like 6 or 7 times, and they never want to go back. And in the hospital, that also happens. I mean, not under your watch, but certainly the phlebotomist from the laboratory in pathology oftentimes is not very expert in drawing blood.
Well, I'd love to give you an example of how we treat outpatients at our hospital.
Yes.
The inpatients, of course, get the team to come, but I saw that the outpatients were struggling, like you said, with phlebotomy. And phlebotomy, you would think, is not on the menu for like a vascular team that's doing more advanced procedures. But I see these people that can't get their blood drawn. So we had a baby, 3 weeks old, that they sent from from an outside blood drawing facility that they couldn't get. They needed 10 tubes on this baby.
10 tubes on how old was the baby?
3 weeks old.
3 weeks old. I didn't know babies had that much blood.
Well, so that's the thing. We'll use very small, microtainers for that. But what I developed a couple years ago was using the femoral vein on babies to do large volume blood draws.
Wow.
And it came to me because the attendings would come up after, like you mentioned, 6, 7 sticks, and they would go into the femoral vein on these kids and draw all the blood, no problem. So I said to myself, why are we waiting for the attendings to come and do that? Why don't we start there on very complex, access patients, even for phlebotomy? Wow. So it's very exciting because we can offer the parents that comfort of saying, look, I know it's an alternative spot, but we can guarantee 1 stick. And on Friday, we did that for this family. And the mother was so relieved. The baby actually didn't feel anything, probably tired from crying.
Yes.
But it's amazing to go in somewhere and be able to do something. And it's amazing to have a hospital that supports alternative ideas to get it done.
That's
right?
Fantastic. Fantastic. Well, we're going to go into the femoral access because I know that a lot of you out there, patients, don't know what the femoral access is, and Matt will explain that as we go. It's often done and it's often not done for a variety of reasons, but with an expert like yourself, should be no problem. Let's talk about, are all patients treated equally? Especially patients with darker skin.
Yeah. So you mentioned the Martin Luther King Jr. Service Award.
Yes.
I didn't even know it existed. I had seen it at the hospital, and it's always a physician, that usually is honored. When we won the Magnet Award for our hospital, which is just a national designation for hospitals that meet certain standards, it's a big deal.
Yes.
We won the National Innovation Award, and we got a grant for $70,000. And they said, what do you want to do with it, Matt? And I said, well, we could buy another ultrasound. We could get another team member maybe to try something. And then I thought, and I said, or we could give it to the frontline nurses so that we could affect all of the patients. And what I was seeing was, and what I was taught in school, sadly, not even knowing that it was an issue, was if you have lighter skin, it's easier to see the veins. If you have darker skin, it's harder. So you just kind of feel it, pat it, and kind of go where it's supposed to be. And I thought to myself, that's not right. That's not right at all. So I got with a company. I went to 2 big companies and I pitched it and I said, I would like to get near infrared light, which highlights the veins. It highlights the hemoglobin in the veins so you can see them better, so that all of our patients would have the same chance at getting access from the frontline nurses. And I pitched it to the 2 companies, and I knew I didn't have enough money to do the whole project. But I said to them, if you guys will give me this project, we will show the impact of it. And we're actually submitting our paper now. But one of the companies gave us the technology, and now every floor in the hospital has a near infrared light. So it doesn't matter what kind of veins you have, the nurse has the ability and the tool now to try to do the best job that he or she can do.
And tell me about obese patients, because that has, when I was in high school, which is prehistoric times, I actually went around and made my extra money in the afternoons after school as a phlebotomist. I actually learned to bleed people. And that was a real thing for a kid who was 14, 15 years old. And it was difficult at first, but tell me about...
Well, let's think about obesity. It has nothing to do with your veins or arteries. It has to do with the tissue.
Right.
So what's fascinating is that with ultrasound, the anatomical locations where the veins are supposed to be on your body are still there. They're just deeper.
Yes.
So I actually get excited when we get called to, a patient that, is larger, because I know that they have the veins. And I tell them, don't worry. They tell me, you'll never get it. No one can get it.
Yeah, that's what they say. And they scare the usual phlebotomist in the lab and the phlebotomist says, oh my gosh, they have bad veins. I'll never get that. And a big arm. So you do ultrasound.
Yeah, well, that is the trick, right? My magic wand is the ultrasound. So without the ultrasound, I am a mere mortal. But with the ultrasound, we really, honestly, we can do anything. And we've been bringing procedures to the bedside that were once only done in the OR or in radiology because of the ultrasound.
Wow, that's amazing. Now, there are ultrasounds that are very small now, pen-sized, I hear. But, we have a big machine to look at joints and muscles and stuff in the orthopedics and rheumatology division. Do you use the little ultrasound, the portable?
So we'll use all different types of ultrasound, and there are mobile nurses that will use the smaller ones because they're more affordable. In the hospital, thankfully, we have a little more high-tech ones. The challenge with ultrasound is this. It's a skill, and anybody can become an expert or at least very proficient with it, but with repetition.
Right.
Without repetition, we look at, is it beneficial or not? Because if you're not good at IVs, and then you can touch the deeper veins and you're not good with ultrasound, what are you really doing? So what I do when I like to train or give the skill away is make sure they have enough repetition, at least 50 sticks, to get comfortable with holding a probe, holding a needle, so that the patient doesn't get stuck the same way they do without ultrasound.
Yes. That's really interesting. Are we helping or hurting patients like superficial venous thrombosis?
Yeah.
Tell us a little bit about that.
So, with any innovation comes it's a double-edged sword. Sometimes you're helping, but while you're helping, you could be hurting.
And what exactly, for the audience, is superficial venous thrombosis?
Yeah, so your veins that you can see in your hands or in your arm, they're superficial, meaning they're close to the surface of your skin. So when you get a blood clot there, although it's not, something you want to get, it's not as harmful as what we call a deep vein, which are the deeper veins either in your legs or in your arms. Right. Those are the dangerous ones. But when you get a superficial, meaning close to the skin, clot, that vein now is gone. And what's happening in hospitals now, and it's really, I would say, the government's kind of fault, is hospitals are being penalized for central line infections. Now, a central line for your audience is a bigger line that goes in a bigger vein, and it allows any medication to go in and blood to come out so that the patients are not getting stuck. But if you develop an infection with that, the hospital gets penalized. So hospitals have to try to survive. And what they've been trying to do is put in these ultrasound-guided IVs into the superficial veins so that they don't have to put in the central line to avoid a reportable infection.
That's interesting.
And that's how we're losing veins. So it's very interesting that where the patients used to get a central line in the intensive care unit, which is where it's more acute, you get the one-on-one nurse and the attending. Now they're coming out of the ICU without veins, and we're putting the central line in on the step down, which is when you come out of the ICU, or a medical surgical floor where you're being treated after the intensive care, emergency has been treated. So to answer your first question, yes, we're doing a little harm and good at the same time. And I think, the scales are going to balance out once hospital-acquired infections become a mandatory reporting thing, which means whether you get an infection from your hand IV or from a central line, they're going to be reportable.
Wow.
So then what are we going to do?
Yeah. It's all about safety in hospitals, and we know quite a bit about safety as a former chair of medicine dealing with all of these issues in our department. We were very, very keen to try to avoid the safety issues, particularly in the intensive care unit. So how is technology allowing procedures once performed by interventional radiology, better known as IR, and by the way, a lot of hospitals send you to interventional radiology if they don't have people like Matt around to do these very interesting vascular accessible procedures. So in interventional radiology, they used to be done, some of that stuff was done in the operating room. It's now done at the bedside. Tell us a little about that.
I've been lucky enough to be supported at my institution. My generation of clinicians usually jumps job to job to job every couple of years because they try to get a pay increase. I would say against that, I would argue that if you stay in one place, you develop the trust and the relationships that will allow you to innovate. And what's happened is with the heart monitor, we call it ECG, but the heart monitor, it shows your heart rhythm.
Yes.
When we get a catheter close to the heart, we have these sensors that can tell us that. So when they would go to surgery or radiology, they would get a live x-ray, we call it fluoroscopy, where they can see all the vessels.
Right.
We now can see it on an EKG, which has allowed us to bring those procedures to the bedside. And believe it or not, when you take the magic of the procedure out of it, all vascular access is a needle and a wire into the vein. And after that, it's just moving things over that wire.
Yes.
So it's become much easier to do these procedures safely and carefully at the bedside.
Oh, yes. And that's very important, for example, for tunnel dialysis catheters.
So,
and, this is really, for those of you who had renal failure or had renal failure, this is an important topic.
Yeah. So for patients with either acute or chronic renal failure, they'll come into the hospital. Usually it's because their dialysis is not functioning, meaning their fistula, the access that they have in their arm, and they'll usually need to go to the operating room to have that fixed, and then they need a tunneled catheter. And predating me, they used to have to wait for radiology or surgery to be available to put these catheters in. And we have a nephrologist at our hospital who's been watching me for a long time. And he said, Matt, you should do this at the bedside. And I said to him, no, I should not. And he, for a year, kept saying, Matt, please, please. And so I did a lot of research. In Australia, they brought it to the bedside. There's a team there, one of my colleagues. And I said to him, his name is Dr. Alexandru, I said, tell me how you're doing it. I got all the literature. I read everything about complications and what to avoid and what is the safest approach without visualization. And we had a really perfect patient in a very good, safe scenario. We brought the rep from the device. We had the attending physician. I had cardiothoracic who was backing me up in the sense of, God forbid there was an issue, they could fix it. It went so smooth. And then the next one, and then the next one. And that's what is exciting about innovation, right? You're judged at the beginning. And if you have a bad outcome at the beginning, usually it doesn't progress.
Right.
So it's always exciting and nerve-wracking for me when I start a new procedure because I want good outcomes.
Absolutely.
So what this has done is it's expedited patients to get their tunneled catheters. They even come into the ER now, and I can put it in the ER and they go home rather than being admitted, to the hospital.
Yeah, that saves a lot of time, money, and it's a very safe thing when it's done with expert hands. That's amazing. So let's talk about Alzheimer's and dementia. This is a topic that's really of great interest to you, the patient. Increasing lifespans are, patients are living longer, and people suffer from dementia, Alzheimer's, confusion, and these are difficult people to deal with from a medical standpoint, but we have to deal with them. There's no question. Can these patients now receive care when they continue to pull their catheters out of their bodies?
Yeah. So again, I work at St. Joseph's. We have the most complex vascular population, the complex patient population that any clinician that wants to learn could dream of. And we've had patients that, like you mentioned, they're pulling their lines out. They can't get their antibiotics. They can't get their nutrition, or they can't get their dialysis.
Right.
So I had heard early on in my career that doctors in radiology, very rarely, would tunnel catheters to your back.
Your back.
So it will come out on the back of your scapula or down here on your back, out of reach of the patient.
Yeah.
So, I went to the chairman of surgery. I asked for permission to try this on one of our patients that they were going to put on hospice, which is end-of-life, care to keep people comfortable, because they couldn't keep his dialysis catheter in. He was going to essentially, pass away because of a catheter.
Right.
I called the nephrologist. I said, let me tunnel this to the back. She said, okay. We did that, and he lived for another 1.5 years. So we do this on patients with dementia that are confused, and we're able to continue therapy. And sometimes to get their mental status back, they just need the antibiotics. They need to get the infection out. And it's a simple procedure. Again, all of this stuff seems so out of the box and
very unusual
but
to
it's
go to the
easy.
back.
Yeah, but it's easy. Because
So
once you get in with the wire, like I said, every procedure is the same, right? A needle and a wire. Once you do that, it's just artwork, with devices.
You just put the tunnel over the wire, and the wire guides it through the blood vessel.
Yeah.
And you can put this on a patient's back.
Yeah.
I mean, I'm sure some of my medical colleagues around the country are seeing this saying, wow, who does that? But I've never seen one, but I can imagine that would be a godsend for somebody who continues to pull out their central lines, their IVs, their this, their that, and never gets their medication. And it's very frustrating for everybody.
I didn't mean to interrupt. We just published on a case series of those. And my job, I'm the beginning of all of this. My job is to put it out there and then have bigger institutions do prospective and randomized controlled trials to really prove that this access, is beneficial to the patients. And that's why I keep developing these things, publishing them, getting the data. If we had poor data, we would not keep going. So thanks to St. Joseph's, administration for supporting me.
Yeah.
We even have the femoral vein, as we talked about at the beginning. This is in your groin area, okay?
We're going to talk about that again because of the business of infection using femoral sticks. A lot of doctors are very, very frightened of doing femoral sticks, particularly in the field.
Yep.
When there's an emergency, a mass casualty event, like a bus rollover or a motor vehicle accident where there are many, many injured people, and you can't get a line because of either trauma to the limbs or because there's hysteria and a lot of panic at the scene. So people do femorals in the field.
So, like you said, I have a presentation I do called Don't Be Afraid of the F Word. And the F word is femoral, okay? But if you say femoral to a physician, they think of the groin.
Yes.
So over my career, I heard how bad it was. And I always look at things that people say not to do and try to make it better.
Yeah.
So one day I went back to my office at Joe's, and I don't know why, I scanned my thigh, and I saw the superficial femoral vein in the middle of the thigh.
Right.
And it's huge. And I said, why aren't we using this site instead of the groin? Wouldn't that change everything and make it safe?
So you went down from the crease between the genitalia and you went down the thigh to like mid-thigh and used that.
Yeah. So we started that in the U.S. And it was primarily for patients that cannot get things in their chest area.
Right.
Dialysis patients, as we spoke about, sometimes their arms are restricted. We did it for contracted patients, and it offered us 2 more limbs to give patients vascular access.
Amazing.
And now it's taken off all over the U.S.
Wow.
We're really excited about it.
That is very, very exciting and very novel. I mean, good Lord.
Well, I collected the data on femoral access, and it was all bad.
Yeah.
And then I showed how I thought we could improve. And to prevent, as you talked about, the superficial blood clots.
Yeah.
If you have a small catheter and a big vein, the blood will flow, and that will prevent a clot. So I said, if we use small catheters in this big vein in the thigh, we should decrease the risk of DVT. And the reason that the clots happen is because the doctors were placing dialysis catheters, which are big in the groin. We're placing small ones, and the deep vein thrombosis, which is the clot that we were talking about.
That's the DVT he mentioned.
Actually has the same rate of occurrence as a PICC line. And we just published a paper on that comparing the two, the arms and the leg. So very exciting.
Very, very interesting. We're going to have to define PICC line because a lot of patients are getting PICCs. And a lot of doctors are very interested in placing them and not particularly well, I might add. So how can vascular access preserve veins in patients with chronic renal problems, for example, kidney disease or end-stage kidney disease? How can vascular access preserve the veins? And I'm referring to the PICC line placements to save their veins, say, for a future fistula. Those of you who have kidney failure know what a fistula is. You might explain what a fistula is because we as doctors take it for granted. We listen to the patients' fistulas all the time when they're being dialyzed. So how can you put that together?
Very simply for your audience, a fistula is a vein that is attached to an artery. Arteries have much higher pressure and flow. It fills the vein so that it can get bigger so that you can puncture it to do the dialysis therapy. So you need a vein. There are grafts, which are artificial veins, but you need these veins to create the fistula, whether it's in the forearm, the upper arm, or higher.
Right.
If we put IVs in there or PICC lines, the word is stenose, but it means make hard. The vein gets hard, and then the surgeons can't use it. So the kidney guidelines, believe it or not, say do not use the upper extremity in patients that have kidney disease in stage 3 or above. You know what your kidney disease stage is if you have your nephrologist. So what we do at the hospital is actually adhere to those guidelines. So we use different veins in the neck with numbing medicine so that you don't feel pain.
That's great.
And in the thigh, which we developed there, to preserve these veins. Now, we need 10 or 20 years to see if we're making a big enough impact on that. But I believe we are. And now the nephrologists, our kidney doctors, are always ordering the correct catheter because we can put that in. So for the renal patients, it's really important to save those veins. Please save your veins.
Yeah, that's really amazing. Let me ask you, people with chronic bone infections or chronic infections that require a PICC line, what does PICC stand for? Do you know?
Yes, I hope so, Dr. Bob. So PICC stands for peripheral, meaning in your arms and now in your legs.
Not in your chest.
Not in your chest.
Or in your neck.
Not in your neck, but peripheral inserted central catheter. So the ones in your chest and your neck, they terminate right before your heart.
Right.
These start in the arm, but terminate by your heart. So they function the same.
Right.
They have lower risk. Obviously, the lungs are not there. The giant arteries of your neck are not there.
Yes.
So they're less risk. They're easy to place with skilled, vascular teams.
Yes.
And they perform very well.
Yeah. At one point, I think we had everybody in the intensive care unit with a PICC line somewhere.
Yeah.
And we really would order or try to get the PICC line installed, especially in the middle of the night. It's not the easy thing to have happen, but it happens. And with guys like you, my God, it's so easy, and you make it easy. So let's talk about bloodstream infections or sepsis. That is a big one.
Yeah.
It kills a lot of people, particularly if you're an elderly person with a kidney infection, or you have a site of an ulcer somewhere that's feeding your circulation with bacteria. So we speak about the femoral vein, which you've already addressed. And the femoral vein is one of the dirtiest. Well, putting it in the groin, which is very sweaty, and I apologize if I'm offending anybody, but it is very sweaty, and some people is very dirty. And here we're putting a big needle in the femoral vein in your crotch and hoping for the best. And we often, with people who are immunosuppressed or people who are elderly that don't have a really robust immune system, they get septic. So what can you tell us about that? Now, you've already told us that you can go mid-thigh, which I think is revolutionary. Well, it's amazing.
I'd like to tell you one more solution for that.
Yeah.
Sometimes if you go mid-thigh and the patient has loose stool or diarrhea or one of the infections that we call C. diff, all of the sudden that becomes a problem. So I thought about it again, and I said, well, what if instead of going for the dialysis catheter, what we do is we curve it onto your chest so that it comes out on your chest.
I see.
I said, why can't we curve the femoral vein to the abdomen? So on those patients where we can't avoid using the femoral vein, we make the exit site on the abdomen so that it's safe and away from any kind of loose stool, which is exciting.
Very interesting.
The other way to avoid infections in patients with tracheostomies, which is a breathing apparatus in their throat, which can have, mucus or leaking around this area, is we can access the vein we need and then tunnel it either to their chest or to their arm. And we did a paper, I wrote a paper with Dr. Pitteruti, who's a vascular surgeon in Italy. So I fly to Italy and I train there because sadly, Europe is the leader in vascular and a lot of innovation, I think you would agree with. So I go there, I watch.
A lot.
And we published a paper on tunneling from the neck or the chest to the arm so that it looks like a PICC line, but it's in a vein that we can access. That's another way that we avoid infection. And the best way to avoid infection is to speak with your doctor and find out if there's an oral option to your antibiotic to avoid access altogether. So, sometimes we forget about the simplest thing. And I always tell my team, if we do nothing, we do no harm. So.
Well, that's pretty amazing. So there's a great future now for those patients who require PICC lines and femoral sticks and all of this that is really very viable. And unfortunately, I have to say that most hospitals don't have that kind of technology or that kind of luxury, and they don't have experts like yourself. So what do you say in a case like that? I mean, what if a patient is home and is becoming septic and the hospital that they go to has not been successful? Do they come to the hospital? Are they admitted, or you can do this in the ER, the emergency room?
You can do this in the ER, but like you said, it's not, there are specialists in a lot of hospitals. There are great teams, great, nurse specialists. The problem is that the administration or just the healthcare system hasn't gone to the outer box limits with vascular access. So I'll give you an example. We had a cancer patient from Louisiana. A student came to me to watch, and she told me about this patient that he was going to stop his chemotherapy because he couldn't get another line in his arm. And I said, well, why don't they just put it in his leg? And she said, well, he walks. I said, well, why don't they tunnel it to his abdomen? So she called the hospital all excited. She talked to her surgeons, and they said, we've never heard of that. We're not going to do that. I offered to fly there to kind of help them, even though I have to tell the audience, I am not a surgeon. So this is not a real big, procedure, but I guess it's different.
Yes.
And they said no.
Very different.
This woman loved her patient so much, she flew them to St. Joe's so that I could do this procedure. And then we videotaped it.
Fantastic.
And she brought it back, and they do the procedure at her hospital now.
Great. Wow, that's innovative.
Yeah.
And that's the way it's supposed to happen. Communication, modern technology should be available to all hospitals in our country. And unfortunately, that is not the case. But we're talking with Matt about innovation across the board here. So we were talking about this cancer patient, but arm ports, that's on my list here to talk to you about. Tell me about arm ports for chemotherapy. I see patients with little reservoirs all over their bodies to get chemotherapy on a regular basis. What about the arm ports?
I have to tell you, if I had to specialize in one thing and one thing only in vascular, it would be arm ports. Arm ports developed a long time ago. They had bad outcomes, and then they became popular again in Europe. And the reason they became popular was for women. Female patients that have any type of cancer that have to get a port put over their breast or in their chest.
Yes.
They can't wear a shirt now that's cut open. They can't wear a dress. They can't wear a bathing suit without exposing the fact that they're being treated for cancer.
Yes.
So by putting it in the arm, there's no trace of it, in the chest.
Wow.
Even the removal of the ports leaves a scar. And there have been papers that say psychologically it really affects the woman, even if she's cured, because she still sees the mark of that port.
Yes.
So they come to us. Again, ports are always done in the operating room or in radiology.
Right.
They come to us. I make a single incision. I numb all the skin so they don't feel pain. We put the port in their arm at the bedside as an outpatient. St. Joseph's was so excited about this. They created a minor procedure room for me in the OR so that any patient from anywhere can come to St. Joe's and get that arm port placed and avoid having that on their chest. Yes. Well, let me just tell you one other thing. Last week was our first pediatric case. It was a 14-year-old girl with a type of cancer. And they were going over it with a doll, showing her where the port would be in her chest, right when I walked in. And I said, hold on. I can put this in your arm. You're so young, you know. Can you imagine having your chest scarred?
Very sensitive
and
age group. Yes.
Yeah. And she was, if you could be excited about anything, because of course cancer is devastating, she was at least happy cosmetically to be able to get her treatment without all her friends seeing this, without her having to hide all the time. So to me, it really touches my heart to help these patients. And we're doing it sooner. They were waiting 3 to 4 weeks to get a port placed by a surgeon because if you go on the list of importance, it's low on their, radar. So we're starting chemotherapy now 3 to 4 weeks sooner by doing this.
Wow. That's incredible. And you're going to have to give us information at the very end of this discussion as to how they could contact you, because I'm sure there are a lot of doctors out there that would like to discuss this with you, and indeed hospitals that would like to hear about this, because it seems like not only are we talking about safety, but we're talking about efficiency, painless insertion, and very interesting areas to place ports and to place vascular access in the body. Mm-hmm. What about our tiniest people, our neonates?
Well, I know I said I would only do ports, but I have to say the neonatal intensive care unit has a very special place in my heart. They called me there when I first started. I remember one of the attendings, and he said, can you place a central line in one of our babies? And I said, I've never done a neonatal baby. He said, I'll talk you through the procedure if you can get into the vein. I said, well, I can get into anything, I can get in the vein. So we did it together. He actually gowned me up and tied me. They were all watching through the window, all the nurses and doctors. Yes. I was shaking, and it went successfully. They called me again a couple times. And then what I found, because they called me in emergencies, and I hate to go back to the F word again, but the femoral approach on these tiny babies was so easy and safe. So I went to the head of the NICU and I said, what if I'm able to use a long needle and start in the thigh and then touch that vein.
Yes.
Then would you be okay with femoral PICC lines in these neonates?
Yes.
He said yes. We started doing it. It is the only thing that we put in our babies as long as there's not a contraindication. It takes 5 to 10 minutes to do. It's easy for the nurses to dress. And we've published on it. We've published on confirming the tip. This is exciting, Dr. Bob. We use ultrasound now to look through the side, through the liver, or through the chest. And we can see the catheter and position it at the right spot on these babies and eliminate X-ray.
Wow.
Which is radiation.
And that's in a little neonate. You don't want a lot of radiation, that's for sure.
From 360 grams up, we access.
Wow.
And it's kind of easy.
My gosh. And a neonate, that's a little itty, and even a premature baby. Who puts the lines in preemies?
So it was the attendings. And they actually, in our NICU, would bring on one of the attendings to spend the whole day just putting lines in. And then when I started coming, they realized that we could do 4 or 5 babies in about 2 hours.
Yeah.
So we were able to save an attending and put them to taking care of either intermediate nursery or other babies that were there. And again, it's so successful from that approach that we really have no complications. We're actually doing a study right now on deep vein thrombosis to go back and tie this all together on these babies. And we've done over 800 of these lines. And I think in our study, we're coming up to like 2 or 3 that we found inadvertently just on a scan. So it's very safe. And then that's what my job is, right? To keep publishing these outcomes so that other NICUs can adopt it.
Yes.
And it's exciting.
Amazing. Around the country, around the world.
Yeah.
Actually, the RAP technique.
Yeah. So
what's that?
Well, I was doing a study on the ultrasound to look at the catheters.
Yes.
I was so excited. I'm like, we got this. And then I would have some false positives where the catheter would be too long and go into the heart.
Oh.
You can't leave a catheter in the heart in a baby because it's so thin.
Right.
Bad things can happen. As long as you pull it back, you're fine. So I said, well, it has to be 100% if we're doing this population. And I went back to my office and I was going to quit. I was going to quit that study. And then I thought to myself, wait a second, what if I'm watching the catheter and I actually retract it into the frame and then A, advance it, and P, position it into the right spot. Right. So retract, advance, position became my technique. And we had 100% correlation with X-ray following that adjustment to the study. And we published that in the Journal of Neonatal and Perinatal Medicine.
Wow.
Yeah.
Well, this is quite amazing. I'm sure you as the audience are really dumbfounded by some of this stuff. I, as a doctor, haven't heard a lot of this. And this is an education for me and certainly for my colleagues who I hope will watch this film as well. Is there anything else that you'd like to wrap up with regard to vascular access, et cetera? And tell us how you can be reached. This is mostly for professionals, but also there are going to be patients that see this film and are going to say, gee, I got to get a hold of Matt because my father is 85 and he's demented and he's pulling every line out and he needs antibiotics or he needs a special chemotherapy. And you've already explained how we can go into that and save this person a few extra years, perhaps.
Well, I'm going to give you 2 answers.
Yeah.
The first answer is if you're a patient at St. Joe's, of course, you can ask for Matt. Everybody knows Matt with the IVs and my team who are fantastic clinicians. But the beautiful thing is they made us that outpatient area. You can just call St. Joe's, ask for the outpatient vascular, infusion area, and they will tell you how to make an appointment through your doctor and whatever you need, we can assess and try to put in for you. Yeah. The second answer to your question is I just got involved in a company for virtual reality, and I'll tell you why. I didn't know what it was. For the older generation, because my children know what it is, you put on these goggles and you're transported into a patient room. A real patient, all the equipment, and it allows you to go through the steps of the procedure so that you can practice before you get to the bedside. It's unbelievable.
Wow.
So the reason I bring it up is people, clinicians, they need some way to practice. And my techniques that are not done, need to be disseminated somehow.
Yes.
And now they can go and download, the course and learn how to do the technique and implement it at their hospital. So we're going global with this to train the world and kind of have something to give back to the next generation.
Yes.
My daughter started Penn State last week for nursing.
Oh, fantastic.
So I keep saying what I do today, thank you, what I do today is for her patients tomorrow.
That's right. That's incredible. This is very futuristic. This is a favorite of healthcare, Health Frontiers with Dr. Bob, is to talk about the frontiers. And I have to tell you, this is really a frontier, true frontier. I mean, we've had many experts, but this is so important and so commonplace for every hospital in the world. You can be in Burundi and, having to put a central line in and have this kind of nuance. The new generation is very much involved in robotics. They're very much involved in reality. What is
virtual reality?
Virtual reality, which is true. Yeah. It's just incredible. And we've heard that some of the best cardiovascular and neurosurgeons are those young guys that used to work the video games, and they have facility with their fingers and with their probes and can do really very, very good things to the human body with expertise. So really, this has been a very exciting program. And I'm hoping that people take this very seriously and that they've learned a lot from Matt Ostroff, who's in St. Joe's Hospital, by the way, is in Paterson, New Jersey. There are many St. Joe's around the country, St. Joseph's hospitals around the country, but this is St. Joseph's Hospital in Paterson, probably one of the most amazing medical centers with a diverse patient population from all over the world, many from the Middle East, the Far East, et cetera.
And those of us that are there are there for the patients.
Right.
It is a charity care hospital. We deal with the patients that don't have the availability to get the kind of health care that someone with insurance could get. So we get them when they're at their sickest.
Yes.
But we take care of them.
Yes.
And that's why we love it.
We do a good job.
We do a good job.
Good. I want to thank you all for watching and listening, and hope that you've taken away and learned quite a lot from Matt Ostroff, an advanced practice nurse practitioner and coordinator and founder of the Vascular Access Program at St. Joseph's Health. And thank you for watching. Thank you for joining us on Health Frontiers. I hope today's episode provided valuable insights into your well-being. Remember, this podcast is not a substitute for professional medical advice, but a source of knowledge and guidance. If you have any questions or topics you'd like us to cover, please reach out. Make sure to like, subscribe, and visit our website at www.healthfrontierspod.com. Join us next time as we continue our quest to uncover the latest in health and wellness. Stay healthy and empowered. Until next time, I'm Dr. Bob.